what type of bone graft should we use? So the first thing, as I told you, all the data I gave you with a bone graft with the temporary having minimal change was with multiple types of graft. Is one better than another? Are there potential problems? The answer may be yes, and you'll see what I mean here in a minute. Let's take a look at Philip. Philip has a fractured tooth. We have to take it out. Here's the fracture, okay? So this right central has to come out. There's the fracture. So I'm going to take it out. Now, the root tip fractured up in there. Now, am I going to open a flap to take it out? Am I going to open a flap to take it out? Whew. Okay, so we didn't waste our time this morning. All right. No, look at how wide open that is. I mean, I need you to see it's like the wide open spaces to you. And that's the way it's got to look to you. With magnification, a little light. I mean, you know, get your 2X and 3X things on and let's go. Here's the diamond stone. Go around the edges and you get purchase points. You go down the ligament space and you create purchase points for your smaller, elevators. And they pop right up. Eventually you get as fast as doing that as anything else. So, bone crest was there. Everything is good. So I'm going to place the implant. This is the self-tapping implant. There it is. So I place the implant up the powder wall as the peak material that we discussed. Empty shell, right? Open it up, the shell, as wide as you have to get it in the proper position. And you get this up and in, and notice it looks like a piece of junk. When you attach the two, the outside shell is being attached to the peak material, and it looks ridiculous. So take it out, get the blood off, and start filling in the voids. And of course, it's going to look like this before you put it in the mouth, right? Now you know how to do that. I'm just going over to you again. You're the restorative dentist in the room. And so this is the shape that I'm looking for. Support the tissue. Here's the temporary in place. Put the straight cylinder on, gives us access to pack the bone. In this case, we use BioOS collagen again, just like I showed you in the previous case. Let's see what happens in this case. And this was the turning point for us in terms of being aware of what bone graft we're using and what may happen to it. So let's watch this one. Now, the previous one, there was no problem, and not problem, didn't look like it was fine. Okay, so let's take a look at this. Pack the bone in, take the cylinder out, place a temporary, and the rest might come out, and that's it. And this is what it looks like day one. There's the graft. There's the graft in. As you see here, the white opaque area. BioOS is always nice on an x-ray because it's radio opaque. So this is what it looks like at 1 week, as if we didn't touch the patient. Everything's fine. Here you see it a little further down. It's still 1 week. Then she had some non-vital bleaching done on the adjacent teeth. Now look at this. This is 5 months. Hello. This is a wake-up call. That this is when we took this off at 5 months and Steve called me in. Now on the outside, it didn't look bad. And nothing came out. Now look at this. This is 5 months. Hello. This is a wake-up call. That this is when we took this off at 5 months and Steve called me in. Now on the outside, it didn't look bad. And nothing came out the outside. But from the inside, we had this adherence of and bleeding. See, it's bleeding. So it had caught, the sulcus was blocking this from letting it come out if it wanted to. So this, remember, BioOS doesn't get resorbed by the body. It's kind of like minimally to none. So it kind of just gets fibrous and encapsulated. So what our concern is, what happens if it can't get out? The tissue adhered around it, and it can't get out. So what's going to happen to this? Should we pop it out? I told Steve, don't. I said, just make believe it's not there. He says, but it is there. I said, no, Steve, it's there. But just make believe it's not there. Don't pop it out. Don't do anything deliberate to it. Go and take your normal impressions. Do everything normal as if it was nice connective tissue. Okay? So let's see what happens to this. So he goes ahead and does everything. But now we've opened it up. Does our custom model. Does the impressions. Takes them. Builds up the case, the opaque material, the layering of the porcelain, like I showed you before. Custom staining, gold plating. Is the gold plating, just to get some extra color, to make sure the color's nice. Now look at what we have here, a nice scenario of looking. Here's 5 months when we first took it off for the first time. Here's 6 months. Notice, look at this here. See, it's almost like trying to get out here. And look at this, now it's gone. And if you look carefully, there's a little bit of a depression. Certainly, it's just one case, and you can't make any judgments, but this does disturb me, the fact that it's still there, and so visibly there. Whether or not this is going to be replaced with tissue as this gets replaced slowly, we don't know. So now we're going back and looking at our cases. Before we grouped all the bone grafts into one group. Now we're going back and trying to get enough cases with different bone grafts to see if any one of them is superior to another, number one, not just at 6 months, which is what the data I showed you is, but what about 2 years? How much of this is still there at 2 years? Has it worked its way out? Does it make a difference in the shape of the ridge? So I want to see this shape of this tissue at 2 years, not just at 6 months, which is what data I gave you, the change buccolingually, which is minimal, but it will get worse or better or stay the same over 2 years. So that's our next data. Hopefully a couple of years from now, we meet each other, hopefully again, we'll be able to pick you up on this to see which is the best bone. Do we want something that doesn't go away or something that does? We're not sure. But I think this is a perfect example of at least gives us a little bit of a, uh-oh, what's all this about? Are we on the right track or should we use something else? Okay? I don't know if I love that. I don't think I do. But, but it doesn't happen on all the cases. It happened on this one. Yes?
I have a question. You lecture on not to use the graft.
I lecture on not to use graft, that it's not necessary. No. Stop right there, son. I lectured to you before in saying that the bone graft is not necessary to get bone up against the implant, because it doesn't matter. What did I tell you the bone graft does based on my data? It'll help keep the shape of the ridge a little bit further out. So what am I doing today? I'm putting a bone graft in. So even though histologically it's not changing anything up against the implant, it's giving me an extra thickness to my tissue and keeping my ridge out. So do I recommend putting a graft in? Yes, feel comfortable putting a graft in. But don't think it's stopping the change up against the implant. Remember, I'll sick him on you. He's going to go right up and beat you all up. He's going to go right through you. That blood vessel right there, he's going to penetrate the clot faster than you will stop him. Okay? Does that help you? So I'm telling you that it's not critical for the histological outcome, but it may be more important, and the only reason to put it in would be for the shape. All right? And that's about a 0.5 millimeter distance. You can see the particles here. Put that in, and there's the final crown in place. Okay? And the result looks great. I think it looks fine. I'm showing you tough cases. Here's the before, and here's the after. I put pre-op and post just so you know. Okay? That's the look at that. I'll take that anytime. Now, I didn't just get lucky, did I? My partners and I didn't get lucky. How many cases have I shown you today? 7, 6, 8? This is what we see every day. I'm not just showing you our best case or cases. This is what we see every day. If this didn't occur this way, do you think I'm crazy enough being in a litigious place like New York City with the kind of patients that I see, the highest levels sometimes? I see everybody, but we're seeing some of the most litigious and most demanding kind of patients, as you all know those patients in your own office. And we see a bunch of those people because we're the end of the line for a lot of people. And I'm telling you, if this didn't happen on a regular basis, if we couldn't predictably say that we can do this on a regular basis, I'd be crazy to stand in front of you and tell you this. I wouldn't do it. It's a great discussion point, because one of the things that we're looking at is by using a platform switch implant, we may be getting an extra thickness of tissue just by having the platform switch. Now, Astra's had this. Ankylos has been very big on this in particular. They've been talking about this for a while. Ankylos, because they have a pretty big size platform switch, bigger than most of the other companies, depends on which implant you use. And they're saying that we think a part of what we're seeing is nice because we have this extra thickness that Jeff is bringing up. That combination of thickness may be very good. We're not sure yet. One of the things that we've found is that when we graft, and I'll show you this new data. What I've shown here, I've shown already. I'll show you some new data that says when we graft, we looked at the buccolingual thickness of our tissue at the free gingiva. From what I mean is not just of the ridge. What I gave you so far is the whole ridge shape compared to the contralateral tooth. But what about in the free gingiva, in the sulcus? What about in here? What about in here? What about 1 millimeter up from the tissue? The thickness of this tissue this way. 2 millimeters and 3 millimeters at the top. And what we have found is that the thickness, if we put a graft material in, that the buccolingual dimension from the outside of that tissue to the inside, when we measure it with calipers, 1 millimeter, 2 millimeters, and 3 millimeters up, went up about 0.5 millimeters in thickness. Why is that potentially important? Now here we gold-plated this story. But if you look up Ishikawa's work, she from Harvard, and we're now doing some work with her on color, with Steve Chu, is a big, one of my partners, as you know, is one of the heavyweights in color and aesthetics. We're doing this joint project with Columbia and Harvard, and we're looking at the, similar to what Ronald Young has done and Irina Sala have done on the buccal of tissue, And they came up with about 2 millimeters as the distance that you want to have as a minimum thickness of free gingiva to prevent this color from coming through, you know, the dark gray color of titanium. Some of that was in animals. They have one in vivo. But the data shows that we get at the gingival margin to average out to about 3.2 millimeters, way over 2 if we get what? At the gingival, at the top of the implant, if we put a graft in. The platform switch may add to that and give us that extra thickness of tissue. Do we want it? Yes, on the labial surface for aesthetics we do. So I think that will help us, you know, deal with that, and I think that's good. And here's the pre-op and the post-op x-ray. They really, they are because of the, anytime you use Prevail or any of the Ankylos or any of the Astra, or any kind of, or tissue level, you know, Straumann, any of these beveled or, you know, implants, they all are going to have extra thickness in that area. But in terms of the contour, we want to have as much support on the free gingiva as what you took out. You don't want to be too much pressure, but you also don't want to be too much collapse. You don't want to be over, because over will do what? Cause recession. You don't want to be too much under, although that's not terrible. I'd rather be under contour than over in the provisional, because at least that will give us extra tissue. And then we can always push it out with the final crown if we need to. Okay? When in doubt, less. Okay? And if that's what you mean, I think that'll be the example of that. Now take a look at this case. Here's a case. Let me show you a couple of oddball things and we started learning from. And so what do we do today? If you don't get initial, here's a case that we're taking off the bridge the same day that the old bridge comes off. You see a lot of inflammation and the tooth is cracked. So we're going to take the tooth out and I'm going to put an implant in because all the walls are there. So I put the implant in, but this one didn't have great stability. And we had a lot of other teeth that Steve's going to shape these up and make it temporary. So we didn't need it for stabilization. So what do you do there? This is very important for the restorative dentist in particular. Instead of putting on a healing abutment, in order to keep the tissue shape for a fresh extraction, put the PEEK material on, take some powder and liquid around the edge and pick up the shape of the free gingival margin. Just with a little doughy mix or just some powder and liquid. You got it? Take it off, unscrew it. It's basically going to make a custom healing abutment. It's like the bottom half of your temporary without the top. So this is what it looks like. See the odd shape? Now the free gingiva collapsed in here, as you see. That's okay. We're going to add acrylic in there. You know how. There's the shape. We're going to add acrylic in here. Add a little more, get it rounded to try to give me back the contour of what came out, like we discussed. And now this is the shape of the, see that, bring that over. That's the shape of this. So now we can polish this, and then we cut this top part off. We don't need it. We just want, you've now made a custom healing abutment. It's really the bottom half of your temporary. And this is what we put in. Nice shape there. Now this one, that's the day of that. This one's going to get some recession because of the fact that this was so inflamed from the previous crown that was on there. It was inflamed. So we can get a little shrinkage, but not much. But what is this doing? It's keeping the shape of the tissue. Let's watch. So we made the temporary, and it's not touching it. It's just right up to it. So it's not involved. And here it is 1 week later. Notice the tissue is still healing. And this is 1 week. Here is it 2 months. Now what have we gained? We've gained the shape of the tissue is still out here. Now I want you to see back here, there's a straight healing abutment. We'll come back to that in a minute. And so we did get a little shrinkage because there was so much inflammation, but not much. Now look at what happens when we take it out in a few months. And 2 months later, we're ready to, it was about 3 months in this case, we take it out and look at the beautiful sculpted tissue. We don't have to now sit there and sculpt the tissue with pressure. And look at the difference here. What I love about this, I need you to look at the one right here. I love this picture. Look at these two. This is a custom healing abutment. The tissue is already shaped exactly the way it was and what we want. Whereas you take a look at this, that's a straight healing abutment. Look at the difference. Now you're going to have to sit there and add acrylic to your temporaries, squeeze it out, and put pressure on it. Okay? So that's the beauty of taking the time to do it now versus then, at the time of extraction versus, you know, later on in the healing. Yes?
Say you wanted to put a temporary on the straight healing abutment side, how much pressure can you put on the tissue to get it to open up or certainly?
Well, there's no way of measuring it, but when we see a lot of blanching, that's usually a good sign that you put enough on for that day. If you have to put a lot more on and it's already blanched, you might have to make a small releasing incision if you want to, in a non-critical environment like the distal area or something, just to give the tissue a little freedom. I only have to do that once. Most of the time the tissues will yield, even if you blanch it a lot, and it's easy to do with a screw down. If you do a cementable, it's very hard, but a screw down, it really, as you're squeezing it down, like a UCLA abutment, it stretches the tissue very nicely. Okay? Yes?
Is there a reason why you're using, at least the majority of cases you're showing gold abutments versus
No, they're gold plated.
okay, so why is it conscious?
We love the color of gold through the tissue. It just gives us a little bit extra security over the metal colors. That's all. If you're more than 2 millimeters, as I mentioned, buccolingual dimension, the gold probably doesn't make any difference at all. Certainly more than 2.5. But at 2 millimeters, we see that based on Ronald Young's work, that we see that there's no major difference with spectrometers through the tissue. We don't see any major delta change.
Can you put a fake material on facial?
Oh, you could if you wanted to, but you don't need it. That's what the gold is. In a sense, it's a more biologically colored aesthetic part. So gold and pink, both of which seem to be more acceptable than the metal, for sure. White is also acceptable. That's why we use zirconium abutments. But sometimes that's too white. And so we're seeing that you use different colored zirconium. So that's also possible. Or you can have a custom-made metal abutment with ceramic baked on the front. And we've done that before zirconium. That's what we used to do. And before the gold plating, okay? So any one of those things are possible. I'll tell you what bothered us the most about most of the cylinders. If you don't use a Prevail, and you use a straight, before Prevail, and you were using just straight cylinders, and I just had this, I have the prototypes now, they just gave it to me today to try out, that the PEEK materials have a flare to the bottom. In other words, they're like this. I don't know if you know what I mean by this. But if this is the, oh, that's why. I'm trying to pull this thing off. It doesn't. Okay. The PEEK material, if this is the top of the implant, and here's the center screw, if this is the PEEK material, it starts flaring almost immediately and then goes straight up. But there's a flare, and then it goes straight up. See this flare? Well, that binds on the bone sometimes. And what you're probably doing is binding on the bone and not getting it all the way seated. And that's why you're probably seeing the screws loosen on the PEEK material. So you really can, because it doesn't show up. So I have two things in my bag just today. One is a radio opaque PEEK material that they're looking at to see it better. But most importantly, it's just, the new ones I've insisted that they come up with a straight top from here up, and then you can do whatever you want. It shouldn't be any wider than, the concept was that will keep the tissue out of the way. But in the subcrestal area at the time of placement, what's the problem? You got bone in your way. You're right up against the palatal wall or interproximal bone. Even though there's a buccal gap, interproximally there's no gap, or minimal, and there's no gap on the lingual. So you're right up against it, and so when you try and put it down, you think you're tightening it down, but you're really tightening against the bone, like I showed you earlier. That's when the healing abutments start loosening in a few weeks later, and that's what it is. So what do? Right now, just grind away that flare, and it'll be fine. That stops, okay? But that's why, as soon as you did that, we had this whole discussion. There's a whole new generation that they're going to change over to straights, okay? So, we've had the same problem, but that's how we got around it. But that's what it is. There's nothing wrong with the it's not the PEEK material. It's that. It's the shape, okay? How you guys doing? You ready to go right through and finish up at like 4? Does that work? Does that work for all of you? Okay. So let me just do a few more nuances, and then we'll finish this concepts up. We'll take a look at this now. What do you do here? This person has a draining fistula. When I put the drainage point in, I noticed it was coming up from the apex, really high up. Now, what should I do here? Now, this patient, as you see, has a fractured tooth. I think it's pretty visible. Now, this is an interesting area. It's different than a very small little perforation. There's obviously a drainage point, but draining here. But what's interesting is this is wider than the opening of the root. How do I know if I go in there that I cleaned it out thoroughly? This is surgically something that we have to face. So what did I do here? Let me just show you what we did here. So I go in and clean it out, but I'm not thrilled that I don't feel, because look at this. See, this opening here is narrow. This is a very large cystic granuloma type area. So I'm not sure I'm able to negotiate this if I want to put anything in that day. So what do I want to do? I want to go and get access to that without doing what? She's a very aesthetic conscious lady, and she was a patient for years and she just cracked his tooth. But she doesn't want any major change to this. Welcome to New York. Welcome to anywhere in the world, right? So you've all had patients like this. And I know I've sent a whole bunch down here, so I know they're all down here now. Okay. So the point is, this is a tough one because this is very low drainage point. When I put the gutta percha point in, I realized the drainage point was higher up, as you'll see. But this is in my way. But here's what I do with these. I do as if I was doing an apicoectomy. I make an incision, leaving, see this here? Leaving in the attached gingiva. And I've cleaned it out from inside and out. And what I do is I'll make a subcrestal incision, leaving this alone. This is only when the buccal crest is there. If the buccal plate's gone, that's not what to do. I told you what to do. Let it all heal, come back and do a boozer in 8 weeks or an ice cream cone. But in this case, I wanted access to the apex. So you see there was bone here, but this is where the drainage was. Even though it was draining low, this is where it is. I'm leaving this tissue intact. And now I'm going to go and now I can get all this rest of this granulomatous tissue out, see? Make sure it's bone clean. I mean, really clean. So I clean all that out. And in this case, I'm now able to go up and get that apical bone, and I can actually lock the implant in. I wasn't ready to feel comfortable putting a crown on it, so we just put a flipper on it. So here you see me first filling the apical bone, leaving this free gingiva alone. See it? Do not disturb. And I pack it in from the top until it starts to come out the opening. I'm packing in from the apex, down and firmly all the way around, see? So I did that, and here's the implant placed, and here's the temporary cylinder placed. I want to keep the shape of the tissue, exactly what I just showed you. And we're going to cut this part off. So now I keep something, the shape is there. And so this is what the patient walks out with this piece cut off, see? So now I got the shape. I have not done anything up there to violate anything. And this is the way the patient walks out with a little flipper over the top. Now, this way she doesn't have any change at all. I've debrided the defect completely. I've got my implant cooking. I've got my shape controlled. And let's see what happens here. And here it is 4 weeks post-op. It's as if, you know, nothing happened. And then we just waited about, I think it was 3 months in this case. This is 8th week. And you can see that this is, you know, just going through the typical mucosa healing, but there's no drainage. And here it is at pre-op. Here it is day 1, the day of the extraction and the graft. And here is the consolidation of the graft taking place at 4 weeks. Platform switch here. And here it is at the 4 weeks, as I showed you. And here it is at 6 months. We put a temporary on, and notice with the platform switch, everything's healing beautifully. The bone graft is filled in, and we engage the apical bone. And we have a nice healing area here. And there's the case completed, as you see. Nice. Yes? Please say yes. Yeah, it's nice. But what was the whole point? I knew where I was going step by step. I did what? Debridement. Debridement without touching, first extraction without opening a flap. The instinct there is to open a flap, start debriding everything. But what's the risk? Mid-facial recession. But she had a buccal plate. So I left it alone. That was not the problem. So I went submarginal and cleaned out the apex, cleaned out the lesion that was wider than the shape of the root. So I made sure I got it cleaned out. Put the implant in. I didn't heal. I didn't put the pressure on it. I didn't put a temporary on, but at least I got the implant cooking, and it was ready to go in a few months. And you see that this is unchanged. There's absolutely no change, and we didn't lose any shape, and she's absolutely estatic. So she fractured a tooth, and we got it clean. Yes?
Are you using antibiotics?
Internally? You mean in the lesion, you mean?
No, either systemic or...
Yeah, let's go through antibiotics for a second. Every patient, the moment they hit a chair that I'm doing surgery, gets an antibiotic, pre-op. When I'm doing any surgery whatsoever, certainly in an infected zone. Now, if I get the patient before this was an emergency that day. But if I get the patient before and I know there's a drainage fistula, I would put them on antibiotics just to get the tissue a little healthier, even though I know it's not going to eliminate the whole problem. But if I don't, the day that they hit there, even if they don't have a cardiac problem or any hips or anything that need to be trained, any orthopedic problem, I routinely give a patient antibiotics. It's true of periosurgery. It's true of implants for sure. And the pre-op is the only major time that you'll see me do that. Now, if I do graft like I did here, I will continue the patient or a sinus lift. The pre-op is most important, but I will continue them on for 7 days and reevaluate at the 7-day mark. Okay? Now, why is that? The only data that we have in dentistry today that implies that antibiotics help your success rate with implants is the pre-op level of antibiotics. It's probably only about 2%, 1.5 to 2.5 in that percentage rate, depending on who you read. But anything afterwards, if I do a surgery on you right now, clean out the defect, and then I give you the antibiotic, assuming you're not a heart patient, like we used to. Just do perio-surgery, we did implant. Here, here's the painkiller, here's the antibiotic. It does almost nothing. In fact, it does nothing. It's amazing, but it does almost nothing. And that's true of medicine, and it's true of dentistry. The only antibiotics that have been any effect in hospitals as well as in our clinic, in our offices, is really pre-op level, the bone level at the time of surgery. That's why you give a cardiac patient one dose right before. The bone level, the blood level at the time of surgery is the most important. That's there to help defend the body from any bacteremia. Now, do I put any in the graft? Absolutely not. But the answer is yes, though. How? It's in the blood. So when I have blood, which is always going to be present around every graft, you have blood around it, the antibiotic is in the blood. So basically, do all my grafts have antibiotics in it? Yes. But it's not mixed in. It's mixed in just because it's in the bodies, it's in the blood vessels, it's in the blood system. Okay? Yes?
Pre-op, meaning day of?
1 hour before.
Okay.
30 minutes before.
And then you continue for a week?
If I did a graft, yes. If I did no graft, if I just did an implant with a perfect ridge and I just put the implant in without grafting, I give them the pre-op and nothing afterwards. Zero. Just painkillers. Okay?
Is that 1 hour before he's orally?
Well, half hour to an hour. The moment they hit the chair, I give them sometimes half a dose, sometimes 1,000 milligrams of Amox or clindamycin if they're allergic, and that's it. Half the dose of the heart level. If they're debilitated in any way, I give them a full heart level dose. And then I decide after the surgery whether or not I want to continue. Did I do a graft? I'll continue. I had an infected site? I'll continue. Okay? If it was a clean site, no. Fair enough? Does that help you with antibiotics? So I thought this was a nice case to show you in terms of what we do. And this I showed you before. So these are our data with the bone graft. All bone grafts mixed together, only 0.3 of a millimeter change. I can live with 0.3 of a buccolingual millimeter change. I can't live with 4, but I can live with 0.3 of a millimeter. And remember, just with nothing, it's only 1 millimeter or 0.8 of a millimeter. Now, platform switching we've done, so we can skip this. Okay. And we discussed the 4 different parts of platform switching this morning. Now, take a look at these 2 diagrams, and hopefully they'll have whole different meanings to you than when you started today. We saw we did our presentation. If you put an implant into a fresh socket and pull the flap over the top, with or without a bone graft, what type of healing do you expect? And no membrane. What do you expect up against the implant? Fibrous tissue, because this flap connective tissue with the blood supply can travel down there faster than the bone can come across. And there's 3 violations that you've done by doing this simple procedure of opening the flap and pulling it over. There are 3 things that are wrong. What are they? One is that the mucogingival junction is now, from up here, could be pulled into the aesthetic zone. And then you got to reposition it up when you uncover. Not terrible, but not necessary if you don't do it. The most important thing, as I told you, expose the buccal plate for possible resorption. From about 4 millimeter average, 3.8, you're down to maybe 10ths or 1 millimeter now. What a difference. That is most important along with this. It would allow the flap connective tissue to get to the implant first. The good news is that most people who do this will put a membrane in over it. Then you don't have to worry about this, but you still have to worry about these 2. If you put a membrane in, it may help hold it out. But, the data shows that may not be too bad. But you still have to then put the tissue back up and get the mucobuccal fold back into place. Simple procedure. If the buccal plate's there, leave it alone. Don't open the flap. I think you got the message. Okay? That's a good summation slide. And lastly, does immediate implant placement preserve the buccal plate of bone? If I put an implant in immediately, will it preserve the buccal plate of bone? What do you think? I heard that implants preserve bone. Depends on when you put it in, whether you're talking about when you put it in or whether it's set. See, a surgical injury of placing the implant is not a very delicate procedure to the bone. So putting an implant in, even if titanium, is very invasive and very destructive to the local area. So placing the implant is not anything helpful to the bone. And there's no blood supply coming from the titanium, is there? However, once integration has taken place, then the bone may be stabilized around the implant. Don't confuse the 2. And a lot of people do. So we know this from Orojo's work and Lindy, that if you just take a tooth out, what's going to happen? The buccal plate's going to move down over 4 to 8 weeks. We've all seen this. The buccal plate's going to resorb. By the way, in this animal study, what did they do? They did a mini flap. They opened up the first 2 or 3 millimeters. Take a look at what a mini flap does to the buccal plate, the blood supply at 1 week. A lot of people don't know about this article, but if you read it carefully, they said they did a mini flap and tried to pull the flap over the top. Now, these are, Rojo and Lindy, certainly one of my heroes, but that's a mistake right there. But you can see the wound healing. Of course, it's going to cause more resorption. You can see it right there. And you see that this is epithelialized already. That's because they pulled the flap at 1 week over the same day of extraction over the top. And the dogs heal much faster. They heal twice as fast as we do, sometimes 3 times as fast. So, but the buccal plate goes down because of that. Now, do you put an implant? Same research, the same year. If you put an implant in, and notice this bone is pretty thin. Take that tooth out and put an implant in, have a good day. Bone's gone again. Same distance. It does not change whether or not the buccal plate will be preserved. This is pretty clear. However, if you take, let me ask you this. Does alveolar ridge resorption continue throughout life? After you take a tooth out. Does alveolar ridge resorption continue resorption throughout life? No implant. Forget about implants. Just take a tooth out. Does alveolar ridge resorption continue throughout life? I thought there was hope for you, What do you think? That's what we're all taught, isn't it? And up to about 8 years ago, I would have said yes, too. But that's not really true. Let me prove it to you. You'll prove it to yourself in a moment. If I take, how's my teeth doing? How's my lower anteriors, okay? Jose 1 and 2. Okay. So let's take a look. Let's say we're going to take a maxillary second bicuspid out. So let's say you're the maxillary second bicuspid. And he just fractured, he's lost, okay? Now you're the first bicuspid, you're first molar, okay? Like you were before. So he's gone, we just had to take him out. All the walls are present, we took him out cleanly, everything's nice. Now, forget about implants. You're going to do a 3-unit bridge. Remember those? Yeah. What's that? Good man, okay. What's that? Okay, so we're going to do a 3-unit bridge. So we make a temp, this is what we all did in school for the role of our lives, and still do with some patients. So we make a 3-unit temporary, and we make him a pontic, right? The same day. No problem, Mrs. Jones. I'll take care of you. We know you lose your second bicuspid. Jose 1, I'm sorry. Jose 2 is going to go, but you got Jose 1 and you got, what's your name? Ramon. So, and Ramon, they're strong enough to take his place. So we put you into a temporary. Now, you put him into a temporary, and how long do you wait before you take the impression of the ridge? You don't take it that day, do you? You wait about how long? About. Not a trick question. What do you normally wait? What do they teach you at school? What do you do in your office? Minimum of 6 weeks, right? And sometimes 3 months, 8 weeks, 12 weeks. I'll give you 3 months, okay? But minimum of 6 weeks. Now, the students always say 6 weeks because they can't wait to finish the case and get out of school. So they want to go rush it. At 6 weeks, what do you have? You have the ridges kind of go through some remodeling, and you have and the epithelium is covered, the connective tissue is kind of covered over the top like we discussed earlier, doesn't it? Sure. So let's say we wait 8 or 12 weeks, and then we wait for what? To get a new shape of the ridge, and we take an impression, we send it to the lab. And they come back and they give us, based on that impression, they give us a modified ridge lap, a pontic of some type. And if alveolar ridge resorption, listen carefully, if it's getting that time of day, if alveolar, excuse me, I get some water. Okay. And vodka. Oh, yeah, I know where your head's going. Okay. All right. If alveolar ridge resorption continued throughout life, then every pontic that you ever made would have a space underneath it. Now, sometimes that does happen. Probably the ones that the 6 weeks, it wasn't fully healed yet. But seriously, think about what I'm telling you. You see it every day. We would never do a 3-unit bridge ever in the past if that space was underneath there a year later. But that doesn't happen, does it? I mean, once in a while we see that. So alveolar ridge resorption, does it continue throughout life, people? In all cases? No. What you have thought about when I asked that is what happens if you do the following. If you take a teeth out, you take out the interdental septum, raise a flap so you get primary closure over the septum, and then put a denture in, sitting on top of it for 20 years, then you get continued alveolar resorption of the ridge, which is what we've all learned and see in our patients. So alveolar ridge resorption continues throughout life if you pound away at the ridge. If you do not pound away at the ridge and just create a space with no pressure on the ridge, the chances are that if the buccal plate's there and you took it out as atraumatically as possible, the ridge shape isn't so bad. So does alveolar ridge resorption continue throughout life in all cases? How quickly we change. Think about that. So don't confuse what happens under a denture. That's pressure necrosis from pounding on the ridge for 20 years. Don't ever confuse that with what happens underneath the pontic. So the question is, does an implant placement stop that? No, the ridge is going to go through some remodeling. But once that remodeling is done, at let's say 3 months, it's done. And unless we do something bad to that, like a partial or something that pounds on it, it won't go anywhere. It's as simple as that. That's why your pontics work. Was that worth the admission price today? What do you think, Nelson? You don't know if that was worth the admission price today? How much did you pay for today? Did anybody pay for today? I don't know. These are important concepts. So now what happens when we put 2 implants in the mandible? Somebody asked me about that. What happens if we put 2 implants in the mandible and we get osseointegration? Does that stop the ridge from resorbing? It does. And in between them it does. Why? Because it won't stop the back. The pounding of the ridge will still, because if you don't get, unless you get 4 in, like a chair, where it has support from both sides, then it'll stop the bone loss. But if you, where it's all tissue, where it's all implant supported. But if you have 2 implants in the front, the bone loss in the front stops because there's no pounding on the ridge in between them. Bone loss in the back can still happen. But you understand the bone loss in the front has been shown to be maintainable, and you stop. Both around the, now we used to think that's from function. That's just from lack of pressure on the ridge. Now the implants, of course, will help keep the bone around it. You know, more trabecular bone builds up from pressure. But please understand that the ridge between there, that's far enough away from the 2 cuspids, like in the centrals, doesn't resorb anymore. Whatever you got stays. Why? Because there's no pressure on the ridge. Got it? Yes? Mm-hmm.
Wolf's Law, I think it is called?
Form follows function, yeah.
Right. So could it have anything to do with that? The fact that these implants or abutment teeth are close enough that not only do they maintain bone around themselves, but...
Yeah, but we've seen it, I think it's a great thought process. And that may be partly true, but the trabecular bone pattern definitely changes when you put pressure on the ligaments around the tooth or implants around the bone. So bone, at least for a millimeter around the tooth and an implant, the trabecular bone from physiologic level loading, not overload, will thicken the trabecular pattern around that. That's Wolff's Law. And that even the trabecular pattern even lines up a little differently. But understand that we see this with 4 pontics in a row. Maxillary anteriors. I've done cases in the past before implants with 4 pontics, and nothing changed. I've all seen that. So that's far enough away that I don't know if that makes sense. You know what I mean? So I put that out to you because I think it's an interesting hypothesis. So does placing an implant into a fresh socket preserve the buccal plate? No, it's going to resorb and do whatever it's going to just by the injury. The answer is obviously no. So where do we conclude with this part, with this discussion of aesthetics and sockets? How does socket anatomy affect our treatment plan? No buccal plate? No implant, not that day. Does the gap distance matter? Yes, with primary closure, not secondary healing. So it only matters if you pull the flap over the top. And does immediate implant placement preserve the buccal plate? The answer is no. What about future research? And maybe this is a good place to end up, and I think, let me just see if there's anything else we want to cover. We've covered quite a bit today, huh? Okay. Let's go through these quickly, and then we'll summate with this. Vertical position of the implant, I think we got, right? Hybrid, we didn't cover. Surfaces, we covered. Immediate socket, yes? I hope so. The rest of you have been asleep all day. Okay. Gap, we covered. Mini width and length, we covered. Pink, we covered a bit in the beginning. Healing time, if you have good stability, healing time with the textured implant is usually about 8 weeks. Could you go down to less? Yeah, you could do immediate too. But remember, at immediate loading, you have no integration. You only have physical, mechanical locking. So even with the fanciest growth factors in the future that we might put on implants, that remember the day you put it in, it's more the thread pattern and the mechanical locking and undersizing of the site, which is going to give you the initial stability to resist the forces. Now, you don't load a single tooth implant ever the day that you put it in. You don't put it into occlusion. Non-occlusal loading is the way to do it. Out of occlusion, tell the patient to stay away from it for 6 or 8 weeks until the secondary integration can lock in. It drives me crazy when I see teachers get up, so-called teachers, I don't even know if they're teachers, but lecturers, I should say, get up and say they're trying to show off for the company. of how good the stability is on their implant. You know, oh, the tape is great and the threads are great. And they get up there and show, hey, you see, here's my temporary, I just put it in, and here it is in occlusion. Here's my occlusal marking stick, you know, my marking spots. Give me a break. That's stupid. You've got all these other teeth that can support the bite during this critical time of healing. Why jeopardize? Why put it into jeopardy? Never do that. It's a waste of your energy and time to put into occlusion. They're temporary. Give it 8 weeks, then you can do whatever you want, okay? So that's a mistake. You want to avoid 150 microns of lateral motion during the healing phase. If you have more than 150 microns during the healing phase of any implant, I don't care what's on it, it's going to be fibrous encapsulated. Why do we get away with this? So single tooth, never an occlusion. Straight lines, be careful. Where do we get away with it? When we go around a turn of an arch. You go around a turn of an arch, the forces are all in a different situation. When you go around a turn of an arch, this is what we learned with teeth, and same thing with implants. If we're going around a turn of the arch, there's no one fulcrum of rotation that I can rotate around. Therefore, there is a fulcrum, but it's in the center. So there's no one line that I can draw through all the implants, different than a single tooth or a straight line. So once you start going around a whole curve with a good anterior-posterior spread, you, just like your chair has 4 legs, you can't rotate, and therefore you don't rotate, therefore there's no lateral motion. There's vertical pressure, which the bone can take, but there's no horizontal movement if you lock them in into the full arch. So when you ask about the shape of the final case, it's do you go around and turn the arch or do you break it up? That was one of the questions up there. Initially, with immediate loading in occlusion, you must go around a turn of an arch. Have to, or else you're putting your case in jeopardy. That's why old implants failed. That's why blades failed. Let's go to blades. You think you'll ever do a blade? Oh, no, I never do a blade. Well, get over it. Because what about if you have a thin ridge, like 3 millimeters, and 2.5 millimeters, you got some marrow, maybe you should just tap a blade in. Take a little piezo. Now that we can make a straight line with the piezo surgery, make a little straight line, tap a blade in. But the blade's going to be used differently than what Lenny Linkow and the previous pioneers did. They did 2 things wrong. One of them I showed you already. That was they were polished. The implants were too polished. They didn't have a texture to them. And what was the other? They didn't load them properly. They immediately loaded straight arch splints and single teeth in occlusion. 2 major mistakes. So they became fibrous encapsulated. Do you think your body knows the difference between a 4 millimeter wide implant, a 2 millimeter blade, or an 8 millimeter implant? Not if it's textured and not loaded. The body couldn't care less to. It's the same. It's the same surface. Got it? So are we going to look at wide? Are we going to look at thin? Are we going to look at... Absolutely. It's coming back, people. If I have anything to say about it, it will. So what are we doing now? We're looking at data to see whether or not we can put blades in with the piezo in thin ridges as part of a full arch instead of doing augmentation. Just like we're looking at molars fitting into a socket. Well, if you have a thin ridge, we're going back. And this is why I'll never forget when Lenny was at NYU, and I kind of inherited him as part of the process when I became initially chairman 20-some-odd years ago when I was at NYU. And Lenny was the most fascinating out of all the guys that I kind of inherited from the dean at that time. And he was the most honest, believe it or not. He says, Dennis, I made every mistake possible. Let me show you what I'd done. And he did. He taught me a lot, but at that time I wasn't listening. It was in one ear. I was being courteous to him. It was in one ear and out the other. He said, Dennis, you want to have success? Blades, anything. He says, go around a turn of an arch, cement the case on. He didn't have screw down at the time. Cement it on to blades, screws, whatever you want. Go around a turn of an arch, and don't take the bridge off for 3 months. Then even if you have to cut it off, the implants will be tight. And I said, osseointegrated tight? He says, yeah, that stuff, osseointegrated. Yeah, that's right. It'll be osseointegrated. And he was right. And here I am, 20-some-odd years later telling you go around a turn of an arch, put the implants all into one fixed splint during the initial healing, and they're going to be tight. They're going to be tight. They're going to be real tight. They're going to be integrated. And we've all proven it. And Jeff certainly has done so much work in immediate loading, too. I remember working on you with this when you first saw us getting involved with it. So, and he's been one of the pioneers in this area now. So when we did that article in 1997, it blew people away. Schnittman did the first one in 1990. I saw that, and I just took it to the next step, added more implants. Listen to Lenny. On my desk in my office at school in Columbia now, I have a very beautiful monument to a thing from Lenny. Not a monument, it's not a plaque. It's I guess a case. And in the case is all the different implants that he's kind of designed. It's like about 150 different implant designs. And I'll never forget this. I asked Lenny. I said, it's in the Smithsonian, a copy. I have the copy that's in the Smithsonian Institute. And I said, Lenny, why did you come up with so many different designs? What's going on here? I said, we got like one screw. This is when I first started with Brandon. We got one screw. What the hell are you doing with this? You got 150 different designs. He said, Dennis, he says, you'll see, you'll come back. I said, what do you mean? He says, you won't be able to use the same screw. I said, I have screws. I have the patents on them. In fact, he did. His screws are exactly what Brandon Mark and the others were using. Self-tapping, what we're using today, not far off, almost identical. Titanium. He used screws also, but he was most known for the implants, for the blades. I said, Lenny, why did you come up with blades, subparasite? He says, I didn't have the ability to build up bone. So I had to, whatever the patient came in with, listen to this carefully, whatever the patient came in with, I had to use what they came in with. I had no way of building sinuses up. I have no way of building buccolingual dimensions up. We didn't have GBR. So whatever the patient came in with, if they were dying and couldn't wear a denture, I had to do whatever they could. They came in with thin bone, I made a thin implant. They came in with fat bone, I did a fatter implant. They had whatever they want. They came in with short, I made short. They came wide, I made wide. And all those implants are in there. And so what am I telling you now? We're basically redesigning what we were given that we know works in standard bone, and in some cases we may not have to graft all these cases. We're going to make it faster with the same efficiency potentially using different implant designs, but know what we're doing. Textured surfaces loaded correctly. So don't block your thought processes. Open your minds. If I've done anything today, I show you that with biology and bioengineering principles, open your minds and you'll be fine. Close it off and you're stagnant. And so it doesn't mean you do stupid things, but they have biologic rationale. So what's the future research? Does placing a graft into the gap keep tissue height and width, even if the buccal bone remodels? We think it does now. And which graft is best? That's still up for grabs, okay? Does platform switching aid in preventing recession? We think it does if you're more than 1.5 millimeters closer, if you're within 1.5 millimeters. We haven't really proven that because we don't want to get closer than 1.5 millimeters to the buccal plate. We'll probably never prove that, but based on our research and the height and recession of others, we see that that this is probably true. The platform switching does. It gives you more tissue, as Jeff, you were asking about the tissue thickness. I think it does with the platform switching combined with the less bone loss possible. Does placing a full contour provision or a custom healing abutment allow for better midfacial contours? I think it does, only because of our research again, but I think it just allows it not to collapse in and you keep what you have. And does removing the abutment affect tissue height? I think the answer is yes. We're not sure how much, and it depends on how thick the tissue is. So I think these are a little bit unknown, and that's where we probably should leave this off. So I think when I look at the list, when to use digital, let's just finish this. Screw versus cement in the same case, I don't see any reason to do that. Unless there's a short clinical crown, then screw has the advantage. Short interocclusal height. Then screw down cases are definitely superior than cementable. But to mix and match, I don't love. Why don't I love it? It's not that you can't do it, but it's a pain in the neck to try to cement and screw at the same time. And what happens is if the cement gives, the screws sometimes will break. So I'm either all screwed down or all cemented, unless there's some very unusual case, okay? So I don't prefer that. Not that it's totally wrong, it's just not my first choice. Digital impression, yes. When you're going to more digital impression, you can enter the digital world at any different places, can't you? You can eventually get to the point where we don't use any goop, except in certain types of cases, but we'll be able to scan the tops of implants, scan encode abutments. We have this ability right now, and most of us and a lot of people are doing it. We don't even have to have a die made up. It could be all virtual here. I think they probably showed you some of this, that the entire thing, and you get it back on an email and say, do you like it? You or the laboratory. You don't have to eliminate your lab. They can see it and see, okay, I like that, modify this, make it a little more tapered, whatever. It'd be a little more occlusal room, and you could design it on your computer. The technician sitting there with wax, molding and doing this stuff is almost completely gone already. They're still out there, and it's still a need, but it's very small. It's going to get smaller and smaller. The technician in the future is going to be a bright computer kid out of high school or out of college. Yeah, that's exactly right. There'll still be a need for some of the old timers, but they're going to just be the guys that help refine what they know works. But the computer guy is going to be the guy who knows how to use a computer is going to make the difference. You can enter it with impressions. You can enter it with the laboratory, any one of which along the way puts you into computer graphics. One piece, if you want one piece, we've been using stuff like zirconzon or the bars that are being used here with Bellatec. They're superb if you're using a hybrid. I don't have a problem with the top unless the bar gets in your way and you don't have much room. But these hybrids, the concepts work great. The one-piece bar has been incredibly precise, and so has all zirconium bridges, like Zircon's on. We've used both with great success. So I'm very happy to say that the computerization world has arrived where we can actually, with logarithmic mathematics, figure out the shrinkage of zirconium and get it to the point where a full arch can fit now. That's amazing. Now, we don't have these in for 5 and 10 years, maybe about 5 now. We don't have them in for 10 and 15 years. So there's still a little question mark about the 10, 15, and 20-year data, but right now, these are working well. In the meantime, the hybrid, like the Bell bars, or Bellitech bars, whatever they're calling it, have been phenomenal. They're incredibly precise. We're really happy with the way they have been for the last 5 years. We've been using them. So we're really happy with that, and we don't see a problem with them. Pink tissue we discussed, put you into temporary, and see how good you are or not. And don't let the patient get involved. Let the patient, after you make beautiful pink provisionals, beautiful teeth with pink filled in to any void, let the patient decide whether or not they want to go through the surgery or they're accepting of what you see. You'll be amazed that some patients will say, that looks perfect to me, or I'm fine with it, even though you could probably do that's fine. I'm okay, you can do that, make it fixed, okay, I'm in. And they buy into it, and that's what you do. So, socket preservation. As far as blood products go, we don't see the need for them. It doesn't mean they're bad to use. They might speed the process up, but the final technique doesn't seem to change anything. So we did this with PRP, that you see that it might enhance their soft tissue healing during the initial phase, but the final product doesn't seem to be any different to us. We don't see any data that prove that we see a different result as a result of using them or not. The Bob Marks has done some work with that, with autogenous bone, but it speeds things up, but it's not the end all. So you can buy a harvester for nothing online right now. Why? Because most people have given up on that. Some people still like it because they like the way it manipulates the bone. It becomes tacky and it becomes easy to manipulate. And the 1 week post-op always looks great. I'm not doing surgery for a 1 week post-op. So some of the oral surgeons, if you have an IV going anyway, or periodontist, you do an IV, and you want to, draw blood and spin some out, sure. It doesn't do any harm. It may do some good, certainly for the soft tissue healing, and speed of healing a little bit. But in terms of the bone and integration, I've seen no data whatsoever in our own data as well in sinuses and other places. So it's not wrong to do, just may not be, it's not the KISS principle. Ridge augmentation we didn't really get into today, but certainly we can do that in a lot of different ways. One of the things that we're working on with the future, peri-implantitis we discussed, occlusion design, very simple. Cuspid guidance, cuspid guidance, cuspid guidance. Next story. Failures, the whole day has been about how to avoid failures, but let's just talk and end with ridge augmentation. I'm working in Columbia now. As you know, I've left NYU years ago now. It's been 2 years, and I'm very happy there. Myself, along with 22 faculty members, have left NYU. So the hub of implants in New York is certainly now at Columbia, and unfortunately what we built at NYU is just a shell of what it was. The brain trust is really 90% gone. And they're all at Columbia. But one of the things that have increased at Columbia, not just increased, but has opened my vision up, is working with Jeremy Mao, who's one of the world's leading experts on stem cells. So maybe no better place to end this discussion than this follows. What we'll eventually do, and the ridge augmentation brings it up, what we'll eventually do is you take a ridge, we're working on this as we speak in animals, you take a ridge and you have a deficiency. Right now you got block grafts, you got particulate with 10 poles, you can put some pins in to help hold the membrane up, and we're doing all that. You got BMP, which is hit and miss, to be honest with you. But where are we going with this? Instead of going to a chin, we're going to be looked at as archaic. I think only as take 3 to 5 years to do this. It's not going to be 20 years from now. It's going to be well within hopefully our careers. You'll take a CAT scan, will show us the exact shape of the ridge that you want to augment. And even on the CAT scan, we can do that now with materialized and Implant. We can pencil in red the exact shape, 3-dimensionally, that you want to fill in. You'll send that to us and tell us if you want something resorbable or not, and we'll do a 3D printer. We can print out that scaffold of that exact shape, exactly, with any size openings that you want, any pore size you want, 200 microns, 500 microns. You can make it hollow, we can make it not. We can make the shell resorbable, non-resorbable with polymers of different types. And then we're going to soak it with stem cells, and depending on what you want in there, most likely bone. And there'll be stem cells that will speed things up, but also be able to stimulate bone growth into this area. And what you're going to do as a clinician, what we're going to do as a clinician, is basically open the flap after we've gotten this to you. You send it back to you. You've done nothing invasive except a CAT scan. You will send that CAT scan email to us, and we will send back to you the exact scaffold that fits that defect, and it will probably also have screw holes in it, so that you can secure it right into the bone. Your biggest job is going to be open the flap, release the flap so that it's passive closure, decorticate the existing bone that's there, screw this on with the growth factors in there, and then that's soaked in it, and then close it with primary closure, and screw it right in. That's what ridge augmentation will probably be within 3 to 5 years. And that's what we see. And is it happening now in animals? The answer is yes. We're going to make it as predictable as we can and as user-friendly as possible, but they're going to look back, and certainly in 10 years, our next group of dentists will come back, and it's periodontists and oral surgeons will come back and say, can you imagine what those guys used to do? They used to take people's chins and their parietal bones and their tibias and all this innovative stuff that we're teaching you to do now. And do you believe that they would put it into the mouth and take like somebody's skull and put it in here? Can you imagine how like brutal and archaic that was? That's growth. So changes take place, and hopefully we've opened your vision as to what you see every day, what you know and what we don't know yet, and where the research has to go.